Our second speaker for today's session, Professor Tariq Waseem. Professor Tariq Waseem is a renowned physician with deep-rooted interest in cardiology. He was former professor of medicine at King Edward Medical University and currently working as professor of medicine at Akhtar Saeed Medical and Dental College, Lahore. Professor Tariq Waseem, please.
Thank you. On? Right. This is. Thank you, Nabil. And so, atherosclerosis is probably the root cause of a lot of cardiovascular diseases, and the spectrum of morbidity ranges from angina and ischemic heart disease and mortality to erectile dysfunction as well, right? The mortality is quite high. We do have about 17 million deaths because of this atherosclerotic disease, and it is likely to rise to around 24 million by 2030. Now, what's this data has been shared by Nabil, our moderator, who comes from Punjab Institute of Cardiology. What's the situation over here? This is the situation in our hospital, and I think Khavar and Bashir will bear me out that the same is everywhere. This is the situation of our emergency department, screening rooms, waiting area. You can't even walk, right? And this is the figure. We have about 1,000 patients visiting our emergency department of Punjab Institute of Cardiology, which is the largest center in Punjab, and we have much bigger over here in, say, Karachi. And of course, the figure would be 1,000 patients in emergency, 100 admission a day, output 3,000 admission from emergency, and up approximately 30,000 admissions a year. And this is 2020, all right? And it must have gone up, and you may have much larger figure if you extrapolate it to all of Pakistan. 7,000 emergency cath procedures every, say, in 1 year. 18,000 elective cath procedures, and about 3,000 surgeries. Now, if this is the situation, what we are doing too little, too late. We are at the tip. There is a lot of burden on the treat, right? And whatever we are doing is that interventions allow the patient to live and cope with the advanced disease and heart failure, and probably not preventing disease at the first hand. So if we want to make some dent into this, we probably need to work down when the disease has just started, right? So there has been, the efforts have been focused primarily on treatment of the manifest disease, what we are doing in our institutions, but this needs to be changed, right? So there is a need for a holistic approach to assessment and to detect and to treat the disease well before it becomes clinically evident in the form of heart attack or heart failure, or if interested, erectile dysfunction, right? So there is, how do we start with? It was 1948 when we first time the Framingham study established that the factors which are responsible for possibly causing atherosclerotic disease, they stand into hypercholesterolemia, hypertension, smoking, diabetes, and if we manage them, we can reduce this risk. Then came this MR Fit or Mr. Fit trial, that if you intervene and if you reduce these factors and you treat them, you are likely to prolong reduce the incidence of manifest disease. Then the famous physician heart study, which about 50 or 60 years ago, we started putting everyone on aspirin for prevention, whether he has or does not have 40-year plus, give aspirin to everybody. And then there was a follow-up. This was statin studies, and the statin probably made the major difference. That starting from 1994, when 4S study was published, there is a lot of data onto that the statin do help, and probably out of the many things, they are the ones which are likely to stay with us for preventive for quite some time. There was a follow-up of this Mr. Fit trial 27 years after the first trial, and it still showed that even 22 years later, it still was benefiting and it was beneficial. We know the risk factors: diabetes, smoking, obesity, physical, the conventional one, and some non-conventional one, and some the newer one. Even autoimmune diseases make you more at risk. Depressive illness, there was talk by Zaman Sahib in the morning, depression and diabetes, depression, heart disease. So that also is a risk factor, right? Then there are risk enhancers. There are conventional risk factors which further increase your risk. Family history of premature disease, chronic kidney disease, metabolic syndrome, preeclampsia and premature menopause has also been linked with an increased or risk enhancing for this atherosclerotic disease. And now this inflammatory disease and immune system and inflammatory markers, they also been, and of course, the South Asian ancestry, we are more at risk of this. Right? So the risk enhancers would be a persistently elevated cholesterol of more than 160 or persistently elevated triglycerides of more than 175 are risk enhancers. In selected individuals, we can measure highly selective CRP, lipoprotein A level, lipoprotein B. For the juniors sitting over here, these are all the markers which enhance or which increase the your chances of patient having this. Add to it albuminuria and add to it a very simple tool of ankle brachial index. Bilal was talking in the morning that we are getting away from the clinical examination more into the tools and more into the gadgets, but there are simple things which can predict your possibility of your patients having this, right? In diabetic patient, there is an additional thing, all right, like duration of diabetes, more than 10 years increases your chances of developing say atherosclerotic complications more. Albuminuria, GFR, retinopathy, neuropathy, and again ankle brachial index comes into that. Now, how much a factor adds to or contributes to? A diabetic has 4 times more risk of developing atherosclerotic disease. Smoking probably increases your risk by 2.5 times. If age above the 40, every 5-year increment increase a risk by 1.6 times, and of course there are other factors as well. So this is the factors which contribute to atherosclerotic disease. And of course having one factor versus multiple factor, that also adds up. You have one factor without risk factor, the mortality probably with multiple risk factor goes 3 times higher as compared to a single factor being there. Similarly, they don't come in isolation. They usually come together or one after the other, right? So you have a previous MI, you are more likely to have 5 to 7 times more risk of having another MI. If you have a 3 to 4 times like risk of having a stroke, a previous stroke, you are 9 times more likely to have another stroke in your lifetime, and 3 to 3 times more likely to have an MI, and same with the peripheral arterial disease. Despite all that factors known that prevention works, treating things probably can prevent the disease at a later stage and probably would reduce or lessen the cost of care. Cost of care, as Bilal mentioned, in the earlier phase would be much lower rather than when it is onto the stenting or cabbage or onto this, and similarly the morbidity and mortality it would be much lower if you prevent it earlier on. But attention on prevention is lacking, and similarly the Bilal posed the question, how many of our institutes have a preventive cardiology setup started on? Is there a dedicated preventive cardiology service at any of our institutes? However,
I think Dr. Howard has it.
Howard has it, probably. The only one, probably they are the pioneer one.
We have it at Taba also.
Right.
Yeah, but other than
and
that.
Do we have a dedicated preventive cardiology program?
Yes.
Teaching program?
Teaching program, no.
Yes.
We are actually starting a MPhil in preventive cardiology.
Right.
We are in the process
because
of
that's where I finally want to bring
to
it to, that we have to set up a dedicated preventive cardiology services or right. So the Pakistan situation is we define the risk factors, and what we do have independently, only 41% of our population is hypertensive, 1% is using tobacco, 21% are obese by definition, 17% have high cholesterol, and 17% plus minus have diabetes, right? So, before we start anything, we need to know the risk. And for knowing risk, there are a lot of tools available. This is a simple tool available on your mobiles, on apps, ASCVD risk calculator, ASCVD plus risk, and just you 1 or 2 minutes data filling can give you your patient's risk of having ASCVD in next 10 years. All you need to do is put in your age, your gender, your race, whether you're white, American, or Latin, or Asian. You put in your systolic blood pressure, diastolic blood pressure, cholesterol level, HDL cholesterol, LDL cholesterol, whether you are diabetic or not, and then whether you are a smoker or not, and whether you are on any hepatitis treatment, on statin, and this would give you, calculate your risk of having atherosclerotic disease or event in next 10 years, right? Okay. Now this is, the calculation comes out. If your risk comes out to be 5% or less, you have a low risk. Between 5.5% to 7%, you are at a borderline risk. Between 7.5 to 20%, you are at intermediate risk. And a high risk individual is who has a risk score of more than 20%. What do? You have this calculation and you have this data. So what ACCA recommends, that those who are in a bracket of 20 to 39 years, they should be screened every 4 to 6 years. Even before, whether we are talking of those patients who do not have any symptoms, they are 20 to 40 years of age, and you have to calculate this every 4 to 6 years, and if the risk is intermediate to high, then we'll talk about the interventions as well. For those 40 to 75 years, you calculate their 10-year risk by using this is called pooled cohort equations, which we use for this, and then in adults or who are at a risk which is borderline or intermediate risk, you have to start additional risk enhancing factors. I just showed you the risk enhancing factors. So you take in consideration of those and then decide about whether any pharmacologic intervention is needed or not. We'll talk about pharmacologic intervention in a moment. Right. Now, in adults with an intermediate risk of 7.5 to 20, or are selected adults with 5 to 7%, if race decision is based decision is that preventive remains uncertain, कि जिसे कुछ देना है कि नहीं देना है. We are talking of interventions, not right. Then there has to be this calcium artery scoring done, and if their score is high, then they probably would be requiring some interventions, right? For adults who have a score between 7.5 and 10 year risk, there we estimate that lifetime risk or a 30-year risk. There is another ASCVD plus calculator, and that will give you a risk for next, say, about 30 years or lifetime risk, and if that has, right, we can beat. This is an area in Japan where government promotes the simple living style, living on vegetarian diets only, and the average age of these individuals is approximately 85 years. So if they can be done, how can be done? We have to start from the basics. Nutrition. All adults should consume a healthy plant-based or Mediterranean diet, rich in vegetables, fruits, nuts, whole grain, preferably. So that is the first point, that we start not from the medication, we start from dietary modification. Then you have to promote the physical activity. All adults should be engaged at least 150 minutes per week of a moderate intensity, or 75 minutes. I hope Professor Javed Akram is here, very enthusiastic about the gym and all that physical activity. Sir, may I have your attention? Your topic, that physical activity. Right, okay. So then the obesity, simple 5% weight loss would give you a lot of benefit in the form of improving your blood pressure, lowering your cholesterol, reducing your risk of diabetes or improving diabetes. And if all this, there are recommendations now that you may think of some pharmacological therapies, or even bariatric surgery if this obesity is in a, say, range which is probably comes into the morbid obesity range. Smoking, and I just want to one comment about this new fashion of this electron nicotine delivery systems or e-cigarettes. They are equally bad. They are equally bad and they should be discouraged. Look, this what we call as vaping and all that, and we have all this shisha clinic and all that coming up. वो सिगरेट हमने छोड़ा था धागे को कागज वाला, तब वो जो उसकी जो नई जगह है वो उतनी ही नुकसानदेह है. So we have to cut down, and also every visit they should be say counseled about quitting smoking, not reducing smoking. वो कभी कभी थोड़ा थोड़ा करके छोड़ने वाला कभी नहीं होगा, right? Diabetes, of course, you need to control that, but Bilal mentioned that this new class of drugs have shown evidence of not only controlling the diabetes but also cardiovascular benefits. And this SGLT2 inhibitors and GLP-1 are receptor agonists. They have shown benefits beyond their glycemic control, and sometimes they are recommended in patients and select patients for weight reduction and for management of this prevention of heart failure and prevention of others. The lipids, so what the guideline says, for those who are less than 19 years of age and have a familial hypercholesterolemia, statin should be started. 19 years at that very younger age. But for young adults, they estimate your lifetime risk and promote a healthy lifestyle first before you think of adding a statin or any therapy. But for those who are a family history of premature atherosclerosis, risk enhancers. Their LDL cholesterol is if at more than 160, a statin therapy should be considered. Preventive, not after he has had a heart attack or a diabetes. And for age 75, there is a question mark that overall lifetime risk assessment should be done, and then you decide about this. Right? Statins, again, the decision to start statin may also take into consideration with a high calcium artery score of more than 100, they should be started on statin. Those with intermediate range, we should discuss that whether or not to start. But those with the risk of more than 20%, risk discussion, and to initiate statin therapy and to reduce LDL-C by 50% should be a preventive strategy. Hypertension, a target of less than 130/80 should be kept in mind and repeatedly on each and every visit should be enhanced or discussed with your patients. Aspirin. We have President Aspirin Foundation here and great advocate of aspirin. Aspirin has been with us, and we have been, this physician art study made us that everybody should be on aspirin. This has now changed. So it should not be administered on routine basis for prevention. To age below 70 years should not be, but it should be considered for prevention at the in those. For a secondary prevention it would stay on, but for primary prevention there is, since the risk of GI bleed and all that, and particularly in patient age 75 plus, you probably have to be cautious about. And in fact this is the latest about 2 weeks ago, this US Prevention Services Task Force, which said that this absolutely not is becoming a more of a repeat. So it should not be absolutely not recommended for those aged above 60 years. I'm talking about primary prevention, not for those who have already had an event. Of course, that still would stay there in patients who have had an event or had an intervention, right? But not right. For those 40 to 59, aspirin could be considered if their risk, which हमने शुरू में calculate किया था, is more than 10%, and should consider stopping after the age of 75 years for primary prevention purposes. What's prevention? Prevention is the action aimed at eradicating or eliminating or minimizing the impact of disease and disability before it has hit you. There are various levels or stages of prevention. The primordial starts with that you have to maintain health and avoid risks. That is, again, healthy living, healthy diet and everything. Then comes the primary prevention, which our topic is today. You reduce and eliminate the risk and avoid clinical disease events, right? And then comes the secondary prevention, that you had an event, and after that, you don't want that event to happen again. So that would be secondary prevention. And of course, tertiary would be where those interventional cardiologists and all those they would come into. So we want to talk about this primary prevention, right? So who does it? That's the important question. State, local government, because we need to have places to exercise, footpaths to walk, right? School teachers who educate parents, peer groups, that would be right. Food authorities, कि जी हमारा जो फूड कंटेंट है उसमें क्या हम खा रहे हैं क्या नहीं खा रहे हैं वो हमें बताएं. Family physicians, the first encounter उसके पास आता है उसका, he should tell us. Or internist, diabetologist, cardiologist, smoking cessation program, and of course all this may have to join. It may not be that's what we call the holistic approach, and that's where this preventive cardiology comes in. That you have to take in everything into consideration, and that cannot be, we have isolated diabetic clinic, isolated hypertension clinic, isolated lipid clinics, but we need to combine them together to have a holistic approach for that, right? So secondary prevention, as I told, probably would be more at after the event has happened, and there of course it would be, again, you need to take people on board, not only the interventionist but probably the internist and family physician as well. Now this is, you maintain blood pressure, physical activity, use of aspirin, diabetes, diet, emphasis on good diet, tobacco. So this is the jigsaw puzzle. You have to fit in each and every this chunk of this pie to complete the prevention. It is a team based. You have to have everybody on board, and it has to be patient centered. You have to look at the patient preferences, cultural background, dietary preferences and literacy. So this is where we need to join. Local authorities have to play their role. General practitioner has to record their blood pressure at every visit. Pharmacists should have a opportunistic technique जब भी आप दवाई लेने जाएं आपका blood pressure भी check हो जाए. That could be a very simple of detection of hypertension. कामरान लशारी, हम लशारी असल में कामरान, हमारे पास कामरान लशारी बहुत है तो हमारे कामरान मुंह से निकल जाता है. Okay, right? And then the community settings, that आप अपनी जो work places है उसको इस तरह से friendly बनाए कि वो थोड़ा सा preventive friendly हो, कुछ चलने की जगह हो. हम एस्केलेटर ना यूज करें, हर वक्त लिफ्टें ना यूज करें. हम ये जो काम है, मॉल में जाएं तो क्या कहते हैं आप उसको, के ट्राली पकड़ने के लिए एक अलग बंदा होता है और सामान रखने के लिए एक और साथ बंदा होता है. वो ओके. दिस इज माय लास्ट 2 स्लाइड्स. फैज सेज, बर्बादी दिल जब्र नहीं फैज किसी का, वो दुश्मन जा है तो भुला क्यों नहीं देते. राइट? सो दुश्मन जहां, ये सारे वो जो रिस्क फैक्टर्स हैं वो हमारे दुश्मन जहां है, और जब हो गया तो हमें कहता है बेदम हुए बीमार दवा क्यों नहीं देते, तुम अच्छे मसीहा हो शिफा क्यों नहीं देते. थैंक यू वेरी मच.